First of all, I don't have anything to disclose. This is a presentation that was prepared by Dr. Lindsay, who is the executive director for the behavioral line at UNMH. And today we get to talk, let me go back to the title. Today we get to talk about the role of groups, which is a really phenomenal complement to what you all do, which is the medication component. And it can help a patient move along in terms of their recovery. And so hopefully by the end of the presentation, you're able to at least describe, if not even identify, but if hopefully even to the point of apply some of the core group interventions, identify what are the best standards for providing group interventions, in particularly for substance use, and then be able to describe the utility of the group approach for differentiating the type of intervention that could meet the best needs in your particular clinic, and even in terms of where your patient or patients are at. Okay, so here are some interesting food for thought, so to speak. So myth or fact, groups are suited for everybody. That's actually a myth. Not all groups are for everybody, and not all groups are for all types of disorders. Groups offer things individual therapy does not. Definitely, you have definitely those interactions with other members in the group, and even in listening to what others may be experiencing and how they might be managing certain situations. The main goal of a group is for everyone to achieve closeness. That definitely is a myth, right? I think that's unfortunately television and movies give it a different spin, and that's not the goal. Group is a treatment of choice for substance populations with substance abuse disorders. Yes. Just what type of groups are the ones that are recommended. And then groups are not tolerated by people with mental illness. Definitely a myth. Perhaps the population that struggles the most would be individuals with PTSD, but even then, the group is very therapeutic. Group pressure forces members to lose their sense of identity and conform. Definitely a myth. You hear some pretty interesting opinions within groups and challenges that people experience. Groups are artificial and not realistic. And I just kind of said that, right? Definitely, there's quite a bit of interaction. It might feel that way as you're preparing your group, but you'll notice if you have a group leader that is not the case. And it's important to know that within a group, there's a process and the technique. The process is the entire thing, right? Like from beginning to end, versus technique. When we talk about technique, is what is it that you're doing, right? What are the role plays? What is the homework or assignments that you're providing participants? So talking about different types of groups. So you have tasks groups that aim to complete a specific goal. Say, for example, if you happen to have an orientation group at your clinic and they get to know what are the services that you provide, what is, so to speak, the menu that they have for them to accomplish their goals. Psychoeducational groups, again, education in some scales, some new scales, as opposed to counseling skill groups where you're integrating a prevention, right? And it's in the here and now. And then these are probably what you're more familiar with, process groups, which, by the way, they're not very strongly, they're not recommended for substance use treatment, especially in the beginning stages and the middle stages of treatment, but more, if anything, towards the end, once somebody has achieved recovery, once they're reintegrating into the community. So that's something important to consider. I think often clinics might try to start with groups, and they start with process groups, and unfortunately will feel that they don't work, but the reality is that's probably not the best recommendation. They can be peer-led, so individuals who have a lived experience with recovery from substance use disorders. And then some of them can be manualized in structure, like the bottom ones. And as you see in this pyramid, it's very important to have lots of psychoeducation groups in your clinic, right? So if you're providing methadone, Suboxone, what are they? How do they work, right? And you can even add skills. Skills groups are going to help your patient to be able to move or navigate through your clinic and even through their own treatment, right? Be able to recognize what is it that they're experiencing, what are triggers, what are urges, what are cravings, what's the difference, etc. And you can use, if you notice, it's the larger group, so you definitely want to offer this to patients at least. And if you are able to have therapists or peers that can lead evidence groups, you also want to have quite a bit of those. I'm going to show examples of what are some of those groups. And then again, when they are in recovery, they're getting ready to go back into the community, being able to have some maybe close, very specific process interpersonal groups. But again, they're very, very difficult to run, especially when it comes to substance use disorders. So if you look in here, this follows the model that we use at ASAP. It's a stage model based on Dr. Judith Herman, who recognized, a psychiatrist who recognized at the beginning, people don't come in wanting therapy, not knowing what they really want. They just know that they want things to stop, right? And so, so it's really good to have for patients when they come in and they're trying to figure out what is the stability when it comes to medication, housing, you name it, right? When it comes to finding that stability, it's good to have some groups that will orient them. So for example, even within our skills groups or ASAP skills groups, we used to have things like, how do you find housing? How do you fill out applications? Things that were at that level, right? You can have for individuals who are coming in with comorbidities, as we often hear in this, in the case presentations with trauma, you can have a group that has some skills built in as to how to deal and manage their symptoms, both as they're starting and as they're going through treatment for PTSD. Sometimes, by the way, we might have patients who are not open to PTSD treatment, and we might be recommending them to go to something like Seeking Safety. You're understanding what is trauma, how does that relate to substance use at a level that it doesn't feel very intense. Once patients are able to get more into the meat of the root causes, then you have groups that are evidence-based, more specific to what they're going through. So let's say, for example, a CPT, cognitive processing therapy, right, that is dealing with trauma, or perhaps ACT groups. And notice that once people are in recovery and the recovery that they want, being able to engage them and their family members, you can engage family here, but you can have some formalized groups at the end. How do they support the family members? What does it mean to live in recovery? What does it mean to help my loved one without triggering them, without making things worse? And then, of course, throughout the groups that you're offering, you're providing your the medical treatment and primary care that all of you are providing, and then any other referrals or coordinations with other services that are needed. Important to know, not everyone has that almost innate skills of being group leaders. It can be taught, but it's important to be able to always evaluate that, because there is the risk, and we'll mention in a second, of having group leaders that are unable to manage group situations. And that can be that can be harmful, right? And we'll talk about some of the risks. But one might be some traits and some skills that you definitely want to ensure that whomever is leading those groups have. For example, in terms of traits, courage, openness, presence, really listening to what's happening in the group, because there will be times in the group where the leader may have to shift gears, right? Maybe depending on one participant or the entire group, you might have to shift gears, and your goal as a leader is always to move them along, right? So that they grow, so that they learn a skill and they're able to apply it. even being able to know when to end things, right? This discussion, now we move to these new skills. Now we practice this skill. Now we talk about going home with this skill, and then next session, remembering, let's review the skill that you took with you to practice. So important to ensure that whomever is helping you, or if you are thinking of developing groups, to work with the group facilitators so that they have some of the skills. So within the group, you have to have a rationale, right? So why is it that we have this group, and the participant understands, right? So we have this group called Inside Out, and it's the approach is self-compassion, and we're going to learn how sometimes we tend to be harder on ourselves than others, and sometimes that can be a trigger for using substances, for example. Objectives, so what is it that we are hoping to achieve, but that is, again, measurable. What is it that is going to happen? Is there a group that is going to send home assignments? Are they going to review it in the group, or is this something individual? And then finding a way so that you can evaluate whether or not that group is successful. It's not unheard of that we have groups here that start, and we evaluate them, and they might not fulfill the purpose that we were having for them, the goal, and either we edit them, or there are times that we just either combine them with another group in terms of like the overall goals, or remove them. So being able to be open-minded. Informed consent and confidentiality, essential for the groups, right? So we want participants to know why they are there. What are the goals? What can they expect from me, the leader, the facilitator? What can they expect from the group? It should be pretty clear. For us, for example, we often have a handout that has very brief information on that. And another part that we have in that handout is confidentiality. We want to teach them, what does that mean? What we talk about, things that we talk about in the group, stay within the group. We want people to keep that information here, but also with the understanding that sometimes somebody might say something. So being mindful, what is it that you're going to share within the group, right? Again, just being able to talk about what might be the consequences if you breach confidentiality. Does that mean your participation within the group, right? One of the, talk about like the expectations, one clear expectation that we have across groups at ASAP that has been really helpful is to say, we don't want anybody coming here under the influence, because that's actually a trigger to everybody else. And so that also ensures that confidentiality, people are aware and are keeping confidentiality as best as they can. We also, in most groups, unless it's a CPT group, which is focused on trauma, in most groups will say we don't want participants to share about traumatic experiences, because that can also be a trigger. And we'll talk about that. Maybe that participant, maybe that's not the group for that participant. So the group leaders' number one job is maintaining physical and psychological safety, right? So we will have group members who are trying to like sway the entire group, or the theme of the group, or even sometimes the discussions. So the group leader must maintain physical and psychological safety. We have patients that, especially like in skills groups, they're just barely making it to your clinic. They're barely learning something for the first time. So that's why it's essential. The leader is responsible to move through the stages. So sometimes, again, you might have leaders that get a little caught on the storylines. And so that leader needs to have the skill to be able to bring them back into what is the goal for the day. Again, we talked about maintaining safety and at the same time, moving the group forward. So it's kind of a really unique balance, right? And as I mentioned, you can have peers, you can have case managers, you can have therapists leading these groups. I know in some of your clinics, you might be short of employees in general, but let's say you might be short in terms of therapists. So being able to do groups would be very helpful. It's just ensuring that they have the right resources. Considering risks, as I mentioned before, confidentiality could be broken. Maybe members feel pressured to disclose something from the group. Scapegoating, right? They for whatever reason choose one individual, and members, it feels as if they're starting to attack one member. Again, the facilitator, the leader, should have that skill to be able to move that and work towards the skill, right? Confrontation maybe in a way that is uncaring. So again, at the beginning, in terms of expectations, we always mention the expectation is for all of us to be respectful, not to talk over anybody else, and to remind ourselves that what we're doing here today is for ourselves. I think in a minute I'll mention in terms of group membership, but you might have individuals who are really, really stressing about ensuring that the group members are doing their work and they're participating, and they're forgetting that the group is really for them. Okay. And then the risk is you might have a leader or a facilitator who is not competent. And so being able to pull that person out, provide whatever skills or training that they need to ensure that there's no harm to the group, right? Okay, so we talked a little bit about that in terms of having rationale. Why are you using whatever specific technique? Is it a skill? Is it psychoeducation? Some evidence-based? And then being okay if you have to make changes, right? And being able to ask the participants, how do they feel about trying something out? We've had cases where we have facilitators in one of their approaches is, okay, everybody has to answer, everybody has to read, and that's not a good approach, right? So we clarified even in our expectations. You can be in the group, you just by being here, you're participating, and so you don't have to answer questions or read. We're just excited that you're here. And that also helps because we have participants who are struggling with anxiety and such. Okay. And that what we're doing is the here and now, right? Remember, process groups is the past. When we talk about skills groups, they're the present. So I think we want to know why, if you're going to develop groups, what objectives are you going to have? Practical considerations. Are you going to have the group once a week, weekly, bi-weekly, an hour and a half? And again, how are you going to evaluate it? All the logistical components of it. Screening for the group, you definitely want to see who benefits and who doesn't. So for example, we used to have an R group, and we used to have it as an open group. And we thought, hey, everybody would benefit. It seems like easier, but in reality, one of the things that we noticed is patients that were just coming in, that were just starting treatment, sometimes were not very aware of some of the things that they were sharing, and so that actually became a group that is it's for advanced stages 2 and 3, right? People who are engaged in treatment, versus skills group where anybody can come in and they can sit and they learn about a new skill. Another thing that we've discovered for some groups, which is, again, it may vary in your clinics, maybe individuals that are struggling with severe mental illness might not be the best candidates for certain groups. Maybe there is a separate group that you have for individuals struggling with severe mental illness. So really knowing your population, your culture, not just the clinic, but the culture within your area. Okay. And then look at time. And then composition, how big do you want the groups, right? So our skills groups got to be pretty large. So we ended up opening several groups throughout the week, right? So we had to put a cap on them. We wanted to make sure that people have room to be able to share their questions, share their responses. As I mentioned, there are exercises for, say, a skills group, because you want them to practice. And some of them want to ask and see if they want some guidance in terms of what they're doing. Open versus closed, meaning, so for example, if it is for trauma, you only have patients who have a diagnosis, a formal diagnosis of PTSD, versus again, an R group where it's just a stage group or based on stages or based on diagnosis. And then how long, right? So most of our groups, we realize, so a lot of the drop-in groups, going back to practical considerations, are standalone. So you might have patients that only come every so often. They're not regular. And so you might have groups where they can come in and learn about something without having to have practiced the previous one in order to connect this new one. And so that would be a consideration. And most of our groups are anywhere between 6 to 12 sessions long, depending on. So the skills where people just come in as they show up, 12 sessions, and there's quite a bit of a variety for them to learn different areas. So for example, in the skills, they learn about like harm reduction, relapse prevention. There's a whole series in there. There's another series that is interpersonal skills. There's another one where they learn about depression, anxiety, and there's another one where they learn about values and the setting up goals, etc. Again, the here and now, reminding our patients that that's what they're doing within the groups versus the processing part of it. And then what happens after, right? So that's very important. Are you going to have 2 facilitators? What if one patient it has a bit of a crisis within your session? Do you have somebody that's taking out that patient? We had a group where we had a therapist and a nurse, and the nurse was facilitating if there was a bit of a crisis and if a patient needed to be taken to medical. And then what are you going to do afterwards? What follow-ups do you have with them after the sessions beyond the group? And reminding patients that this is for them, that this is what I was telling you, like that what they're doing within it is for them. If nobody else participates and they want to participate, that it is okay. That it is okay for other participants not to participate. Okay, so this is the last questions that Dr. Lindsay had in here, but just curious if you have any questions in terms of groups. I think it's just a really good way to complement what everybody else is doing in terms of that medication treatment. Sometimes the groups help the patients even identify what their goals, what do they want for their goals for the mental illness side, the therapy side, sometimes even in terms of what are some goals they want to fulfill if you have a peer within your team or case manager. So they serve so many purposes. So curious if you have any questions